patient safety issues. And with that, I'll just hand it over to our co-chair, Pamela Leish from HealthNet.
Okay, great. Thanks. Welcome, everybody. What we wanted to do today to start out, it's been a little while, is just quickly go around the room and have everyone introduce themselves, say where you're from. I think it's good for us to check in every now and then just to remember who's all here. This is a great networking opportunity for everybody. So I think we start here in the front and we'll just go around the room clockwise.
Hi, I'm Chad Vargas from the Health Services Advisory Group. I'm the coordinator of the LA UVP.
Debbie Nixon, I am the corporate advisor at Health Services Advisory Group.
Hi, I'm Liz Helms, and I'm the president and CEO of the California Chronic Care Coalition and the San Diego University of Best Practices Coordinator.
Hi, I'm Juliana Burton. I'm the Assistant Director of Pharmacy at UC Davis. I cover the Care Services.
Hello, my name is Stephanie Roberts. I am a second-year pharmacy resident at UC Davis. I'm specializing currently in ambulatory care with an emphasis in transition care.
My name is Kim Buss. I'm a family practice doctor with Sutter Health, and I work on diabetes management especially.
Amytis Towfighi with California Rural Legal Assistance Foundation. And we're here because we focus on farm workers, and we just recently, 2 years, we just had our anniversary at a clinic health reopened in Knights Landing. And we're hoping it's a model for the rest of the state.
I'm Susan McClare. I'm a medical consultant at the Department of Healthcare Services Medical Managed Care Division. Olivia Kasiri, Public Health Officer for Sacramento County.
Hi, I'm Sandy Merrick, account manager with Novo Nordisk.
David Matsumura, I'm also an account executive with Novo Nordisk.
Hector Rodriguez, Associate Professor at UC Berkeley School of Public Health.
Hi, I'm Brian Hayes with the Northern California VA Healthcare System. I'm the Associate Chief of Staff.
Hi, I'm Mike Washer from Dave Grant Medical Center representing the Air Force.
Don Hubbard, I'm Chief Medical Officer at Western Health Advantage. I'm Warren Barnes, Regulatory Consultant at UC Berkeley School of Public Health and pastor of Grace Presbyterian Church in Sacramento.
I'm Eva Krejcinovic with United Care Health. We represent unionized hospitality workers across the country.
I'm Scotty Webster, medical director for Aetna, Northern California. I'm Elaine Wood, the Capital Coordinator for the Safety Future Medication Adherence Awareness Campaign. I'm Lisa Ashton. I'm the Health Services Advisory Group and the new Pharmacy Director for Pharmacy Innovation.
I'm Kurt Peterson. I'm one of the neurovascular coordinators for DD.
Sure, Deputy Public Policy Director, California Chronic Care Coalition.
Jessica Nunez de Guevara, the California Department of Public Health. Just wanted to let you know, since we talked last, the California Wellness Plan has been released, and I look forward at a future time to speak more on that project.
I'm Gil Sun. I'm the Medical Director of Chaplain Family Medical Clinics.
Wanda Borges. I'm the Associate Dean of Graduate Programs and Community Partnerships at University of San Francisco. All right.
I'm Bill Remek, Chairman of the California Hepatitis C Task Force, and on the steering committee of the California Chronic Care Coalition.
I'm Betsy Thompson. I'm the Chief Medical Officer for the Centers for Medicare and Medicaid Services in Region 9 and in the Public Health Service as well.
Hi, good afternoon. I'm Mary Ferguson, Chief Medical Officer for Health Services Advisory Group.
Thanks, Mary. I'm also Medical Director for Southern Independent Physicians and also co-director for this Right Care Initiative.
And I'm Hattie Hanley. Most of you know me. I'm the director of the Right Care Initiative. I see Dr. Davis Liu just came in from Kaiser. Thank you for being with us. And Dr. Ivy, did you have a chance to introduce yourself?
No, do you want me to
stand up or just?
Dr. Ivy with UC Berkeley School of Public Health is our Right Care Clinical Research Director. And I want to acknowledge the effort that the Sacramento Public Health Officer has made, Dr. Olivia Cassirier, for being here. And I also just want to notify everybody of a big important deadline before we get started, and something to tune closely into when we hear from Dr. Amytis Towfighi in a few moments, and that is that next Wednesday is the deadline for public comment for whether or not to drop the LDL 100 standard from the NCQA HEDIS guidelines. So we have found this to be a very important measure in the Right Care Initiative, and there is unsettled science discussions happening around the new guidelines. So I just thought I should give you a heads up about that. And with that, Pamela Leish will be doing the introduction of our speakers.
Great, thank you. And again, thanks everyone for coming. Before I get to that, just a quick reminder on the second to the last page for any people who can do continuing medical education or continuing CEUs. Don't forget to go to the website and fill out the information, because you do get continuing education for today's program. So let's get started. It's a pleasure for us to have Dr. Amytis Towfighi that is up here today from USC, Keck School of Medicine. She's an assistant professor of neurology, and she's also an associate chief medical officer and the chair of the neurology department and chief of the stroke system of care at Rancho, Los Amigos National Rehabilitation Center. So Amy originally is from the East Coast. She's been out here in California, and her focus has really been a lot on focusing on ethnic and gender disparities and how to deliver the right care to everybody. So this is a great time for topics. She's going to speak with us today about stroke prevention and with a little bit of a focus on women. So with that, welcome Dr. Towfighi.
Introduction. It's really a pleasure for me to be here. I did spend 12 years on the East Coast, but I actually grew up in Kenya, and so that's where my interest in healthcare began. That's when I decided that I wanted to be involved in reducing disparities, and so that has been my focus as a physician.
So Dr. Towfighi, while they're getting the slides going, Dr. Towfighi was with us at the Stanford Summit in October and started our awareness process in the unusual signs and symptoms for women related to cardiovascular disease. And that's one of the topics that she'll be touching on today.
So the objectives of this talk are really to go over 3 important new guidelines that have come up in the last couple of months. One is JMC8, the next one are the new guidelines for cholesterol management, and finally the new guidelines for stroke prevention in women. And to discuss these guidelines, which are all a little bit controversial, and to figure out how to incorporate them in Keck. So as most of you know, heart disease, cardiovascular disease affects over 1 in 3 individuals in the U.S. And once you get to the age of 50, if you're free of cardiovascular disease, 1 in 2 men and 40% of women will develop cardiovascular disease. This translates to 1 death every 40 seconds, and 1 out of 3 deaths in the United States is due to cardiovascular disease. The Inner Heart study looked at the global burden of cardiovascular disease, looking at individuals in 52 countries, and found that the population attributable risk approximately 90% can be attributed to predominantly modifiable risk factors such as smoking, diabetes, hypertension, abdominal obesity, diet, physical activity, and alcohol intake, with moderate alcohol use being protected. So the American Heart Association has released their 2020 goals. They reached their 2010 goals, and by 2020, the goal is to improve the cardiovascular health of all Americans by 20% and reduce deaths from cardiovascular disease and stroke by 20%. So in order to do this, they identified ideal cardiovascular health. So that includes a healthy diet, which includes 4.5 servings of fruits and vegetables a day, 2 servings of fish a week, incorporating healthy grains, limiting salt intake, and limiting sweet sugars and sweetened beverages. Regular physical activity, which they define as 150 minutes of moderate intensity activity per week. Not smoking, normal BMI, so that's 18.5 to 25 kilograms per meter squared. Optimal BP, and this was defined as less than 120/80, so we'll talk about that in JNC8. Optimal total cholesterol, which was maintaining it below 200, and optimal fasting glucose, maintaining it less than 100. And using data from the National Health and Nutrition Examination Surveys, which is a cross-sectional sample of the U.S. population, this is how we're doing in the United States with respect to these 7 risk factors. As you can see, 72% or 3/4 of the U.S. population is in the 4 diet score region. Half of the U.S. population doesn't get at least 150 minutes of moderate intensity physical activity a week. 36% are outside of the optimal BMI range. And the numbers for total cholesterol, blood pressure, and fasting glucose don't look great, but they don't look as bad as the physical activity and diet scores. So hypertension is the premier risk factor for both heart disease and stroke, and there have been significant improvements in the prevalence, control, awareness, and treatment and control of blood pressure. Back in, this is also data from NHANES, and from 88 to 94, 1/4 of the U.S. population had hypertension, and the prevalence of hypertension increased to 29% in 2007 to 2008. However, control rates increased to 50%. The mean blood pressure decreased, awareness increased from roughly 70% to 80%. Treatment rates also increased, and of the individuals who were treated, approximately 70% were controlled. So as a vascular neurologist, I will be talking quite a bit about stroke. There are 800,000 strokes per year in the U.S. 1/4 of these are recurrent strokes. It's the 4th leading cause of death in the United States and the leading cause of disability. And just to give you an idea of the stroke burden, 1 stroke occurs every 40 seconds. And stroke recently became the 4th leading cause of death. It used to be the 3rd leading cause of death. So this slide shows you the overall decreases in the last 40 years in both heart disease and stroke deaths. So the red line is cardiovascular disease and heart disease, and the blue line is stroke. You can see that the death rates are significantly higher for heart disease compared to strokes, but there's been a steady decline. And this is a paper that we wrote a few years ago when we saw that stroke had become the 4th leading cause of death. So This is where the cross occurred in 2008. Chronic lower respiratory disease used to be the fourth leading cause of death and became the third. We actually recently wrote an American Heart Association scientific statement discussing the reasons for the decline in stroke death rates. And actually, probably the most important reason is blood pressure control over the years. Prior to writing that paper, we actually looked at organ and disease-specific causes of death. So if you look at stroke or heart or MI, those are both organ and disease-specific, but cancer is not organ-specific. So if you break up the cancers, then what we found is that stroke, which had been the second leading cause of death, organ and disease-specific, had decreased to 5th in men and 4th in whites. However, there were still significant gender and race disparities such that it was the second leading cause of death in women and blacks. The disparity, the race-ethnic disparity, is not necessarily due to differential decreases in death rates over time. It's just due to the fact that death rates are significantly higher in blacks. So you can see the slopes are roughly the same for the different races. It's just that the death rates at baseline have been much higher in blacks compared to other ethnic groups. The other key thing when we're talking about disparities is that race-ethnic minorities and those who are socioeconomically disadvantaged are less likely to lead healthy lifestyles. And you can see with the inner heart study and also the inner stroke study, which both showed the importance of lifestyle with respect to reducing cardiovascular risk. So we're going to focus a little bit on blood pressure now. It is the strongest risk factor for heart disease and stroke. And for stroke, this is based on when there were 700,000 strokes a year. If you prevented hypertension, you could prevent over half of the strokes that occur. Sorry, if you controlled hypertension, you could prevent over half of the strokes that occurred. So this is the old table from JNC 7, which defines what normal pre-hypertension and hypertension are. Normal being less than 120 over 80, pre-hypertension in the 120 to 139 range, and hypertension is over 140 over 90. And a third of US adults have hypertension. It's responsible for 70% of heart attacks. So I did a study a few years ago looking at hypertension control amongst stroke survivors, because you think, okay, everybody, these are people who've already had a stroke. You would assume that their hypertension control is pretty good because they've already been admitted for a stroke and started on medications to reduce their risk of recurrent stroke. And what this was based on NHANES again. These are individuals with self-reported history of stroke who had blood pressure taken at the time of their assessment, and half of them had poorly controlled hypertension, meaning over 140 over 90. And here I defined control as 140 over 90. And 8% did not know they were hypertensive. So they said they didn't have a history of hypertension, and their numbers showed otherwise. And then we were curious to see, well, what are some predictors of poorly controlled blood pressure? Who are the groups at highest risk who we should perhaps focus more attention on? And we did a multivariate model and found that age, so increasing age, female sex, Hispanic ethnicity, and comorbid diabetes were all associated with worse hypertension control, and having diabetes was, if you had diabetes, you were 2 times more likely to have poorly controlled blood pressure than if you did not. So this brings us to JNC 8. there's been quite a bit of controversy in JNC 8, and I'll be curious to see how you all are interpreting the guidelines. The key aims of this guideline was to determine what are the thresholds at which to start antihypertensive medications, and what should the goal be? So how low should you go? And what are the roles for different classes of antihypertensive medications? So the methodology of JNC 8 was quite different from JNC 7. JNC 8, they went with the Institute of Medicine guidelines for developing guidelines. And so they developed strict criteria for their literature review. They did a systematic review. They limited the studies that they used to randomized controlled trials, and they had specific size thresholds for randomized controlled trials. And they also did not include any trials that enrolled people who were not hypertensive at baseline. And so this has caused, some of the skeptics have said, well, you know, a lot of trials have shown that starting in high-risk groups, starting a medication irregardless of the blood pressure may be beneficial, so why didn't you include those trials? They also looked at hard endpoints, so any kind of morbidity or mortality caused by hypertension as their endpoint, so they didn't look at surrogate markers. And then after the systematic review, then a panel used a standardized protocol to determine the guidelines. So the key differences in JNC 8 versus 7 with regards to the goal is that they increase the goal to less than 150/90 in individuals over the age of 60. And the basis for that was that there were no randomized controlled clinical trials of a sufficient size to advocate for a lower blood pressure goal than 150/90 in that age group. The under 60 and those with chronic kidney disease remained at less than 140/90. And the goal to decrease it to less than 130/80 for diabetics was removed. So individuals who have diabetes, the goal was changed to 140/90. With regards to diastolic versus systolic, there were no significant changes in JNC 7 versus 8. And this is just a really quick table just summarizing what I just said, that the 150/90 is for those over the age of 60 and everyone else less than 140/90. Now with regards to medications, there were significant differences between JNC 7 and 8. So in JNC 7, the first line agent was recommended to be a thiazide diuretic. However, now they're recommending any one of 4 drugs, 4 classes: thiazides, ACE inhibitors, ARBs, angiotensin receptor blockers, and calcium channel blockers. And they are pretty flexible about how you start medications and titrate them up. So they say, well, you can start one, reach the max dose, and then add another, or you can start one and then add another and titrate different medications. And so they allowed for flexibility in practice of titrating medications as long as the goal is achieved. They were pretty clear to say that other than those 4 medications, the others should be third line after you haven't been able to achieve blood pressure control with the first, second, and third line meds. Now there were a couple of caveats in blacks. They recommended using calcium channel blockers and thiazide diuretics instead of ACE inhibitors and angiotensin receptor blockers. And in those with chronic kidney disease, they recommended using an ACE inhibitor or an ARB as the first or second line. And the only combination they recommended against was an ACE inhibitor plus an ARB. And in those who have chronic kidney disease, that you can use calcium channel blockers and thiazides instead of ACE and ARB if you're over the age of 75.
Dr. Towfighi, could you go back to that slide, please? Could you talk about why there's a difference there between how the black patient should be treated from the other
all-use recommendation?
Yeah, so there have been trials that have shown that in blacks, thiazide diuretics are, show better efficacy than ACE inhibitors and angiotensin receptor blockers, as well as calcium channel blockers. So there are trials that have shown that, and so that's why there's that difference in terms of choice of medications.
So this has come up in other university of best practices in the past, that the African American population is very difficult to manage for blood pressure. So maybe sometime we'll have you come back and build that out a little bit.
Absolutely, sure. So the next guidelines to talk about are the cholesterol guidelines that just came out. These were meant to replace the ATP3 guidelines, which came out several years ago. And these guidelines, basically they came up with 6 or 7, 6 to 8 recommendations. A couple of which have been controversial. The first is that regardless of what your LDL is, lifestyle modification is critical from the beginning through treatment. That's something that you should really emphasize with patients. And as I mentioned before, the ideal healthy diet that is being advocated is very similar to the Mediterranean diet. Low saturated and trans fats, low sodium, high vegetables, whole grains, emphasis on fish, poultry, legumes, olive oil, nuts, and limiting sweets, sugar-sweetened beverages, and red meat. Again, regular exercise, abstaining from smoking, and maintaining a healthy BMI. Now, with regards to starting a statin, when do you start a statin? So anybody who has evidence of any kind of atherosclerotic vascular disease, so any patient with a history of MI, stroke, TIA, peripheral vascular disease, or any revascularization procedure should be started on a statin. Amongst individuals who don't have any cardiovascular disease, if they have an LDL of over 190, they should be started on a statin. And if they have diabetes, they should be started on a statin at a lower LDL threshold, if it's 70 to 189. And if their 10-year risk of cardiovascular disease is at least 7.5%. So they developed a new risk score to replace the Framingham coronary risk score. So Framingham, as you all know, was in a population that was predominantly white in Framingham, Massachusetts. So they used data from 5 population-based cohorts funded by the NIH to develop risk scores applicable to blacks and whites. And so that was the risk score. They didn't have, not all of the cohorts had sufficient Hispanics to include them in the scoring strategy. The third guideline they have is about monitoring. So this actually really significantly changes practice. In the past, if patients were on a statin and ALT and CKs were checked to look for side effects. And what they said is it's not needed unless they have symptoms. So you don't need to check aminotransferase levels and CKs. If the patient has symptoms, then you check it, and then if the levels are abnormal, then you can stop the medication. And then they also emphasize to actually check for a history of any kind of muscle symptoms prior to starting the statins, because often it's really hard to tell if it's due to the medication or not. Now, the next guideline is regarding primary prevention in those who have an LDL less than 190. So they say if your 10-year risk of cardiovascular disease is at least 7.5%, then have a conversation with the patient, explain the risks and benefits, and again, encourage healthy lifestyle habits. And these are the 5 cohorts that they looked at to estimate the risk scores. ERIC, the Cardiovascular Health Study, Cardia, MESA, and REGARDS. So the next guideline is about the intensity of statins. So this is actually, I think, one of the important features of these guidelines is that because in the past, it's been really hard for practitioners to advocate a high potency medication based on their formularies. So in someone who's less than 75 and has atherosclerotic vascular disease, they should be started on a high intensity statin. And the next slide will show you what those are. In addition, if their LDL is over 190 or their risk at 10 years is calculated to be 7.5%. Moderate intensity is going to be amongst individuals who have some kind of safety concerns. Maybe they've had some symptoms, maybe they have some liver issues. Individuals who are older than 75, and also for primary prevention if the LDL is less than 190. So these are the high, moderate, and low intensity statins. The only high intensity statins are atorvastatin and rosuvastatin. Moderate are the REP, atorva and rosuvastatin at low doses, and then the remainder can be used. Although simvastatin has been studied at 80 milligrams, they're recommending not increasing it beyond 40 because of the side effects of simvastatin. And the others at lower doses are low intensity. So this, I think, is one of the key slides, and relevant to what Hattie was mentioning about changes in looking at, instead of looking at LDL levels, the ACRQ has proposed looking at just statins, but I think it matters what statin you're on and how much of it. And they're saying, well, we don't really know what levels to titrate the medications to. So you don't really need to check LDL levels. However, the reason to check them is to monitor adherence, not to titrate to a certain level. I can tell you, if somebody is on atorva 80 and their LDL is 110, they're probably not taking it correctly. And so, how much time?
Sorry.
Yeah, I think it's, so for the remainder of the time.
Being our clock keeper, 25
It was too engaging, I forgot all about it.
25 minutes.
Okay.
25 minutes.
So the last 25 minutes are going to be spent talking about the new guidelines for stroke prevention in women. I participated in writing these guidelines. It was actually a very exciting endeavor because we've never had guidelines for prevention of stroke in women. And women obviously have different risk factors, different outcomes, and so it was an important guideline to write. So the incidence of stroke is higher in men than women at all ages except for over the age of 85. However, women live longer than men, and stroke is more common in the elderly. So what happens is that more women than men have stroke each year. And so the burden of stroke is higher in women. The aging population, by 2050, stroke incidence is going to be 50% higher in women than men, looking at the overall population, not age specific. And we do know that stroke outcomes are worse in women than men, and I'll show you a little bit of data on that. Another key challenge as a society is that elderly women are more likely to be alone and socially isolated, so they're less likely to get to the ER in time, and they're more likely to be institutionalized after a stroke. There are some sex differences in stroke amongst, which are quite poorly understood. There's thought to be that estradiol is thought to have some vasodilatory effects, and studies have shown that cerebrovascular reactivity is more robust in premenopausal women however, decreases after menopause. There's been a lot of basic science research done on this, and it's still incompletely understood. With regards to stroke type, subarachnoid hemorrhage is more common in women compared to men, and women are more likely to have cardioembolic strokes. And this is due to the fact that the prevalence of AFib is more common in older individuals, and stroke is more common in older individuals. Men tend to have large vessel atherosclerotic disease and comorbidities, including coronary heart disease. Most studies have shown that functionally women do worse than men. One Swedish study showed that 67% of men were independent in their activities of daily living at 3 months, compared to 54% of women. The Framingham study had slightly different results, with women being more likely to be independent. And the Michigan registry study showed that women had a lower odds of achieving independence in their activities of daily living compared to men. Nearly all studies show that women have a lower quality of life after stroke, and as we mentioned before, they tend to be older, have worse pre-stroke function, and more likely to be socially isolated. With respect to rehab care, studies have shown no significant differences in terms of access to occupational therapy, physical therapy, and speech. And there's probably not a big difference in response to therapy in men versus women, although one study showed that women do worse. So, switching gears to unique stroke risk factors. Women have several risk factors that men don't have, namely pregnancy, oral contraceptive use, hormone replacement therapy, and they also have some factors that affect them more than men. For example, migraine is much more prevalent in women compared to men. And then an area of my research is really looking at the effects of obesity and metabolic syndrome on stroke risk. And some of my research focus shows that women are more susceptible to the effects of obesity and metabolic syndrome with respect to their stroke risk compared to men. So in terms of pregnancy, the high-risk period, Kittner did the landmark study in New England Journal many, many years ago, and showed that the high-risk period after pregnancy is 6 weeks. However, just a few weeks ago, Camel from Cornell did a lovely study looking at data from California, which showed that the high-risk period is actually beyond 6 weeks. It goes up to at least 12 weeks. And that was published in the New England Journal. With respect to your relative risk, for ischemic stroke, the relative risk postpartum goes up approximately 9-fold, and for intracerebral hemorrhage, 28-fold postpartum compared to non-pregnancy, with an overall adjusted relative risk of over 2-fold for pregnancy and the postpartum period. The highest risk period is the first couple of days after delivery. So previously it was thought that hormone replacement therapy is protective for stroke risk. However, several studies went against that. So the women's estrogen stroke trial showed that estrogen replacement did not reduce the risk of stroke in individuals who had stroke or TIA. The Women's Health Initiative actually showed an increase in risk of stroke, and the secondary analysis showed that in the first 5 years, if it started within the first 5 years of menopause, there may be a protective effect for heart disease, but not stroke. The other unique risk factor for women is preeclampsia, which is defined as elevated blood pressure in the setting of proteinuria. And the guidelines do address preeclampsia, So we suggested considering a low-dose aspirin and calcium supplement therapy for preventing preeclampsia and stroke, and to treat hypertension early, as preeclampsia increases your risk of stroke twofold and your risk of hypertension later in life by fourfold. Now, what are the thresholds at which to treat the blood pressure? We said to consider treating if you're at moderate levels of hypertension, so that's the 150s to 100s. And once you hit 160 over 110 to treat with blood pressure medications during pregnancy.
What's the state medication you use during pregnancy?
So there have been studies looking at thiazide diuretics, beta blockers, however not atenolol. Metoprolol has been shown to have minimal side effects, and calcium channel blockers such as nifedipine. Sure. So the other unique risk factor are oral contraceptives, which increase risk of stroke by approximately threefold. And they're particularly harmful in individuals who have other risk factors, such as diabetes. And amongst individuals who use oral contraceptives, one should be more aggressive about treating their other risk factors. Another key thing is that oral contraceptives can increase blood pressure, so screening for hypertension prior to initiation of oral contraception is recommended. Or not just oral, any kind of hormonal contraception. And as I mentioned briefly before, migraine is more prevalent in women compared to men. And although the prevalence of migraine is approximately 20% in the general population, about 4.4% have migraine with aura. So aura typically are visual disturbances, so flashing lights, a homonymous hemianopia, but you can also have sensory deficits, weakness, and difficulty with speech. So that would be so individuals who have migraine with aura are the ones who are at high risk for stroke. And they're particularly high risk if they also take oral contraceptives and they smoke. So we generally would exercise caution in starting oral contraceptives in someone who has migraine with aura or who smokes. So in terms of the guidelines, we mentioned to screen for hypertension prior to starting the oral contraceptives, to advise individuals who have migraines to stop smoking. And then finally, since atrial fibrillation is more common in the elderly, to screen for atrial fibrillation amongst women over the age of 75. So in summary, cardiovascular disease, as you all know, remains a leading cause of death despite significant advances over the past 50 years. A great proportion of the population attributable risk for stroke and heart disease are behavioral risk factors, which can be modified. JNC8 had a few key differences from previous guidelines, including being less aggressive with the target for older individuals, being more lenient with the choice of medications to use. And the new lipid guidelines suggested to use high potency statins in the setting of individuals with cardiovascular disease, and not to necessarily titrate to a level, but to just make sure they're on a high potency statin. And finally, the guidelines for prevention of stroke in women really highlights the unique risk factors that women have and some of the management strategies to prevent stroke in these individuals. So I left about 10 minutes for questions. Otherwise, we can get started on the work groups early.
Did you find with your research whether or not elevated HDL mitigated any of the risk?
Yeah, so there have been several studies that have shown, especially for stroke, that elevated HDL is associated with a lower risk of stroke and has a protective effect, and may be potentially a stronger factor than LDL for stroke risk.
In your research with women, do you have a breakdown, racial breakdown? And could you, if you do, can you talk a little bit about it?
Could you repeat the question? Yeah, so in my research for stroke in women, do I have a race ethnic breakdown of stroke? So the main findings when I've looked at race and ethnicity are that so blacks have a higher risk of stroke than whites. They are less likely, and blacks and Hispanics are less likely to have their risk factors controlled than whites, and they have poorer outcomes. There haven't been any large national studies looking at this. We're basing our research on population-based cohorts, which may have certain ethnic groups and not others. And a lot of the research I've done has focused on using NHANES, which is a cross-sectional study. So you can't really make causal associations. But in general, there are race-ethnic disparities in stroke incidence, prevalence, and outcomes.
So I just want to point out that everybody has the Sacramento data brief in front of them, and on page 2, there is detail about the demographics of Sacramento County's heart attack and stroke patients and the disparities issues. So we don't have to go into it now, but there is a higher rate of stroke and heart attack in Sacramento compared to the state. And we show variation according to ethnic group on the bottom of page 2.
I'm sorry. Yes, 2 questions. The first is, you mentioned the importance of screening for atrial fibrillation, and my question is it, I find it very, interesting that you state that, because I've not known anyone who's had the condition that didn't feel bad. So are there cases where people don't recognize that their heart isn't functioning and think they're fine, and then stroke out and lo and behold, it's because their heart was fluttering and they didn't appreciate that is what was causing them to feel poorly?
Yeah, so the question is, do you have asymptomatic atrial fibrillation? And the answer is yes. And so, for example, in patients who've had a stroke where we suspect a cardioembolic stroke, we do screen for atrial fibrillation. And there's more and more data showing that just a 24-hour Holter is probably not enough. You can do the implantable monitor for a month or longer-term Holter monitoring. So we definitely do see patients who have atrial fibrillation or paroxysmal atrial fibrillation, which is the same, confers the same stroke risk, who are asymptomatic and don't know it.
And then my final question is, you had mentioned a trend that in the future women are going to be impacted more. I think cited like 50% higher levels. And can you explain a little bit about the source for that change? Is it because women are projected to be in poorer health moving forward, and so that they're having those impacts younger? Or is it because the demographics are changing such that more of the ethnic minority populations you described are becoming a larger proportion of the population? And I'm just trying to get a sense of
So those numbers are not, so the question was about why is the burden of disease of stroke projected to be higher in women by the 50% higher by the year 2050? And what are the underlying causes for that? So the those projections are based on the aging US population and on the fact that women live longer than men. So it's not as complicated or well thought out.
To some degree,
we
it
suggest.
can even be worse than that projection is probably.
Yes, absolutely. So it could be worse because, for example, Hispanic women are more adversely affected by obesity than other race, ethnicities, and men. So those estimates may be of 50% more by 2050 might be an underestimate.
Right. Thank you.
I was wondering, with the decreasing prevalence of cardiovascular disease, but the continued disparities that we're seeing, when you look at the geographic regions of the country most impacted in the stroke belt, has there been a difference in that decrease, either perhaps a higher, a faster rate of decrease, or a slower, since there is a very large African American population in that stroke belt? Wondering what we can learn from that, if anything.
So, for example, the question is about regions of the U.S. where there are disparities. Have there been different rates of decline of heart disease and stroke? And a good place to look would be to see if the REGARDS trial, the regional and ethnic differences in, I think, atherosclerotic risk disease, something like that, where they do focus on the stroke belt. So I don't know if they've looked at differences across time by race ethnic groups. I imagine they have. When we looked at national data, there was that one slide which showed that rates of stroke mortality are decreasing for all different race and ethnicities. It's just that the burden of disease is higher of stroke mortality in particular is higher in African Americans. But I would have to see if they've done a recent study.
I am just wondering if we could talk a little bit about the slide you showed about the big difference it would make if we could get blood pressure under control. And I didn't tell you before you came that this group went through a prioritization process last summer where they prioritized two things. One is education of the highest risk patients about their risk for heart attack and stroke, and educating not only the high-risk patients, but their families who would be the witnesses that would get them to the necessary treatment. But secondarily, a regional blood pressure control campaign. So we did have one of our members here, Gil Simon, the doctor in charge of Sacramento Family Physicians, reporting this morning that just by following the Measure Up Pressure Down campaign, they've really turned their numbers around for blood pressure. So I don't know if you want to say anything about that, Gil, and whether you have any questions for Dr. Towfighi about the Measure Up Pressure Down campaign.
Sure, I'd be happy to. Just learned that this morning, that our data can be interpreted. Thanks to HSAG's information people, we are able to look at our data. And a year ago, we had roughly 48% of our hypertensive patients under control. And then following the planks of the Measure Up Pressure Down program, which mainly the plank that was most effective was not letting our hypertensive patients escape our control. Our medical assistants became pit bulls, and anybody with a high blood pressure was not allowed to leave the office without a return appointment to see them in 2 weeks. And they came back every 2 weeks. So during the course of the year, we tripled the number of visits to for hypertensive patients, and the rate of control went from 48% to 64%. I'm very proud.
Thank you.
So could you also just say a little bit of something about the special risk that asthma patients and diabetes patients have for heart attack and stroke?
So asthma and diabetes both increase your risk for cardiovascular disease. And
So can you make recommendations of how to deal with those populations as high-risk populations? I think, for instance, we often see our groups at goal for hemoglobin A1C control, very important, but maybe not paying attention to that blood pressure and lipid control.
Absolutely. So individuals with diabetes should have, basically they're at higher risk for cardiovascular disease. So their blood pressure and lipids should be controlled. Previously, we used to say that individuals with diabetes should have tighter blood pressure control. But after ACCORD, we no longer say that because there was no benefit to less than 130/80 in potential harm. But it is a key factor that it's not enough to just treat the diabetes. And a lot of this is within the constellation of metabolic syndrome. So individuals with diabetes also have abdominal obesity, hypertension, dyslipidemia, and it's not just the LDL, it's also HDL and triglycerides, which are abnormal, in which case lifestyle management is incredibly important in these individuals.
Okay, there's one more question, and then I think we need to move on.
Dr. Ravela.
Well, go ahead.
Okay, so thank you, and congratulations, Dr. Simon, that is awesome. Activate, Communicate, Engage, RACE, California Chronic Care Coalition, that's RACE. When I look at 50% going up, okay, as a consumer, I'm outraged to think that as we are working on preventable diseases and control of cardiovascular disease, in particular, control of blood pressure, lowering the effects of the possibilities of stroke, how can we sit here in this room and say by 2020 or 20, that we're going to be seeing 15% because the population is older, when we know if we can activate people, we can get them on the right meds, we look at comorbidities of chronic diseases, playing into cardiovascular disease, that we can prevent and drop that 50% way down, and that's what I'm hoping for.
Right, I couldn't have said it better. So, thank you. And I think, one thing to, a big focus of my research has been on sex differences in women, and particularly in, sex differences in stroke, and particularly amongst younger individuals. So the stroke rates, individuals are having stroke younger than ever before, and there have been gains in blood pressure control, lipid control, but the two things that are worsening over time are obesity and diabetes, which comes hand in hand with that. So if we don't target lifestyle, then everything else we're doing is not going to have much of an effect, because the lifestyle is such an important factor in preventing heart attack and stroke.
Thank you, Dr. Towfighi. That was an excellent presentation. And, particularly because this is such brand new information and some of those controversial areas, this is a great presentation, and I'm sure there are a lot more questions, but we wanted to move on with the second piece of our right care, which is where we break you up or ask you to stay in your groups, and actually for the small groups, if you could join one of the other tables, because this is where we really want our groups engaged in addressing some of the questions that have come up. And so you see for the next 30 minutes in our agenda, we're going to ask you to, at your tables, to take on these 3 questions, or if you can, at least take on 1 or 2 of these questions, and then we'll take some time to report back from the tables. And again, this is a very important and critical piece of right care, is our desire to collaborate amongst ourselves and see what's happening in Sacramento. And by the way, Gil, again, great results, and you're leading the way for us, so thank you. First question is, based on today's presentation, which new guidelines will you implement in clinical practice to reach the goals for blood pressure and lipid control to prevent heart disease and stroke. Question 2, which new guideline or guidelines can you include in your clinical practice that could help you prevent stroke in women in particular? And then finally, which practical prevention strategies will you prioritize for your highest risk patients? And if you could discuss this amongst yourselves, and then we'll take the time to hear from the group. Thank you.
Number one. I still had side effects with muscles, issues. So if you're going to switch over and put under this new guideline, 5 potency, statins, what's the higher risk? I don't understand. What's the trade-off?
There's more benefit than risk.
And some of the statins have lower rates.
Are we depending too much on statins and not making some of the life changes, behavioral changes?
Lifestyle is harder to change.
Yeah, so that's why I asked whether you were using a health
It is a health coach.
because I think that's what's important.
It is. They're kind of, they're de facto health coaches without really, they have a training program. You talk to them and educate them, and they have, vitally interested in health services. Most committed part of our So that's the bottom line. I know that some places actually have training for formal education.
So we could put that in that deal that I know
That would be terrific.
That's the same amount of San Diego. They look in the doctor's office. They got to pick whoever they felt was the key staff person, who that person was. Who's going to be across the road. And so we called them on Sunday. Right. I don't know what the numbers have come down. Last Monday, there's and heart disease strokes on the heart, yeah, from the
Yeah, and this and then implement. So I think that piece will be good. And then also for the lipids, dropping out the requirement for the LFTs, the liver check, and the CK is a big plus too, because, just having that one more barrier, and I think what I understand is they just looked at the data and really the only people who changed were people that were symptomatic. So it's like, why would you even do the blood work? So I think that's going to save us moving forward. It'll make it one less obstacle getting people on lipid control.
And testing for LDL, it's really just a matter of testing it every
So for this first question, it says which new guideline will you implement for blood pressure and lipid control? Are we all saying we're going to implement the newest, the JCA requirements, or?
Well, I think it's pretty hard to go against it.
Yeah. So for that, we'll say, we're going to move forward with the JNCA. What was the other one? And then we'll just put the caveat about going to more simplified 140/90 should make it easier to implement from a team approach. And then removing the requirements for blood work for lipids will make it that much easier to move forward with that piece as well. I think it also, it asserts to the patient that the med is safe.
And then they aggregate their family members or talk about, kids, creating them or, like the more you get the message that you need to be healthy, even if you have a lot of barriers to eating, the more as a community you can say, what are our barriers? And why do those barriers exist? And how can we work on overcoming one of the interesting things I heard that meeting with that person pointed out that a lot of patients have the fundamental belief that their physician's trying to poison them. It's like that, it's like until you convince me otherwise, I actually trying to poison me. And so you're giving me all these and so if they're not going to make me feel better, why would I take them?
A relationship with trust and confidence, and that means whether it's our pharmacist,
So you're not saying
well, no, I guess the question is, how do you
the pharmacist tells them this will in other countries where it's prohibited here, it has to have doctor's prescription. In other countries, it's
So see, you guys should tell the patients without them not privately knowing
Physicians, in addition to the other guidelines, these 2011 women's guidelines, and certainly make sure you have those conversations for the young woman in particular who's, childbearing, just in particular, that's the one group that talks about lowering deaths associated with cardiovascular disease. It's still a 34 to 44-year-old that is dying at a higher rate. We are lowering women of other ages, but not so much that it's not even on the and it seems to be this one, if you end up with gestational diabetes, within 5 to 7 years, you're at much higher risk, right, for diabetes. And the same thing with preeclampsia, there's a percentage of them that never recover from blood pressure. So they're being watched, but that other group isn't really aware of that. So it's significant. It's like 13 times more likely to have cardiovascular disease, with those early challenges. So it did change the risk profile. But the cardiologist researcher, and she's still here. She just literally chewed us all out because these guidelines have been out for a couple of years. She said nobody's paying attention to them. But I didn't really feel like these guidelines existed.
Well,
guidelines only take 17 years to implement.
I know, we always talked about that, yeah, exactly. I know, exactly, no, exactly. Okay, she was here. It's Villamont, V-I-L-L-A-B-L-A. Yeah. I sent her an email because I was running after the guidelines came out.
We're going to put you on medication. We're going to try and get your blood pressure down, whether it was straight to a guideline or something. I mean, they generally have some kind of guideline in their head that they learned over the years, trained and taught and by experience and read about. But, you know, the fact that they're paying attention and emphasizing that to the patient and wanting to follow up and so on, as opposed to, well, let's deal with your earache. Today you came in for an earache or a backache, and your blood pressure was high, and then not following up on that. Not saying, well, you know, I want you to come back and check it in a month or what have you. And then if you get them on a treatment program to really, you know, do it right and go for it. That's what you know, the guideline use that as, but to address the problems and help manage the problem.
I would think blood pressure would be one of the easier ones to manage, because every time you go to a physician, that's what you do. You wait, you sit down, they check your temperature, they check your blood pressure.
Yeah.
Put you in a room. Every single time they weigh you. Those are the three things that are done every single time.
Oh yeah, no. Treating hypertension, again, it's pretty darn easy, unless it's refractory hypertension. Sure.
So what do you guys think of, this is the first time I've ever heard of a relationship between stroke and over-the-counter contraception. All of them, pregnancy.
You go to your RP.
Don't emphasize that.
You get reads for your prescription on my opinion, but I'm a part of a big system, you know, in San Francisco. I'm not in.
I guess I wonder, just based on your peers or friends or professional contacts, is that guideline for women, you know, and those risk factors and managing those risk factors, do you think that'll be new information to most?
I don't know, because I'm wondering, so your experience is you knew that I have very low blood pressure, and I'm wondering if on the individual side, even though for years he's been prescribed those medicines, is the fact that it wasn't an issue for him, because even if it was causing high blood pressure, the individual level.
Like, see, the way my practitioner starts,
Do you smoke?
Correct. So if I would have said yes to these things, then I think she would have launched into this diatribe about birth control.
And so I think I can answer, yeah, I think that's.
And I don't smoke, but I knew I know, I've read about it concerns and stuff, but quite frankly, you know.
Right.
Because, you know, I guess in terms of where I was going with this is like, you know that what gets measured and reported gets paid attention to.
Right.
And will this new guideline for women or risk factor awareness change?
But I think the issue is whether it's already been there, and it just hasn't, the dots haven't been connected before, but for actual patient experience was being raised.
The relationship with stroke became apparent very soon after the birth control
So it just took a while for the guidelines to incorporate that evidence.
But initially it was attributed to the higher doses. So if you go back, you know, they became available right about the time I got out of med school, 63. Okay. And it was by, you know, the 1970 that it was recognized. And then the efforts were to find a lower dose of estrogen that would again suppress ovulation, but not carry the risks. And it seemed clear that there were some people who were susceptible to the effects, stroke effects of the high dose estrogen. And and smoking may have been one of those risk factors. Coexistence of, but every other thing, but so this effort wasn't, this is brand new. Now, if you want to say in a large population study, say that it's not a big surprise that you would find in a large population of women taking anti-inflammatory agents that they might have a slightly higher incidence of stroke than, but then when it comes down to the individual patient, so the woman wants some kind of birth control. So, is this a reason not to prescribe an anti-inflammatory agent? Maybe you hit on something if it's a diabetic woman who smokes. But that's individualizing. What about the perfectly healthy woman?
It's always the clinicians are out there for 40 plus years, but the newness is actually seeing.
Here's
It's
a
all been loosey-goosey. Here's the guide.
Yeah, that's what I mean.
Somebody being a practitioner, somebody who was experiences.
Let's do it. What's the secret? It's like,
That they would electronically share the discharge summary and the discharge instructions with Walgreens Pharmacy right across the street, so that when they see their pharmacist, the pharmacist can go through the med list and do reconciliation. And they weren't able to do it. I mean, they fought for over a year. It set the project behind by a year, and they said they threw up their hands and said no. So they're going to use either the blue button, which is available to Medicare patients, or Health Vault, which is Microsoft's personal health record that's available to everybody. So that's what they decided to do. Then they tried to work with Epic to share the data. Because, yeah, well, and what's sort of unfortunate is that they'll, if the patient says they want it, they'll fax it to them, or the paper-based thing where we'll share it. If the patient comes and signs something, we'll hand it to them, and they can bring it in when they see the pharmacist, which is like isn't ideal, but isn't ideal. It's a start. It's a start, but it's the beginning. They can log in with the patient and actually make the corrections right on that record, and then the patient can take it to their primary care or their specialist and go back and log in and make it's not ideal. It's not ideal. It's a baby step. It's baby We answered three. I don't know which practical prevention strategy you prioritize or highest risk.
Well, actually,
that's real managed care versus the FKC, which is pretend managed. And the reason it's pretend managed is because you always have the back door. So you can always say, just come back into this. Just come back into it. And yeah, the back of the office paying sliding tables and now this able to come out. It can't be waived, but often these organizations so they don't. But I actually have a more on point suggestion, which is the formularies for the
determines the different then that's
why would you establish the national
if we were to have adopted one standard, and benign, I mean, it's sarcastic to society.
The single thing that I've heard in the last 7 weeks.
Are you taking our conversation?
And all of my prescriptions were rejected. I got to rewrite all of my prescriptions.
Well, the real question.
Because nobody told me that they were changed.
Well, and I would imagine that any standardization may come from situations like that, where people just decide to have no uniformity so that docs aren't out there.
They weren't 60, but the industry kept, but they're going for 30. You can't stop it, but the idea is to get public pressure, and get the insurance commission to step in, and because particularly people who are the coping meds and get stuck with it, I want a chance to go to see where it's going. So it looks like it's going to pay off. It's got support of both parties. It's a very nonpartisan issue.
I find your formulators to be fairly cautious and arbitrary.
They usually are. It's not about.
I'm no expert, I'm not an endorser, but pretty
Part of the discount too. That if you get the discount,
I started my post-cardiac after various adjustments, so I went from $15 a month to almost $200. That's in addition to my $1,200 and not touching the deductible. Just my monthly medication is $200.
Were you able to write any of that off on your tax bill? It's usually medical
It was.
In your face.
I definitely don't want that to be recorded.
But it's true, it's true.
Talk about something.
So I go
Our co-chairs.
offices all the time, and I occasionally spend time watching and a couple of times I watched I watched the and I thought, maybe we need to focus on how we measurement of bodies. But the other piece
right size cuff.
Yeah.
I mean, it's just simple things like
just
that.
simple things like that.
Or where the sensors, especially with these automated ones, you find that the sensors are here, it's not going to take
Yeah, no, you're right. And just a very simple thing of, hi, Mr. Gonzalez, why did you have a seat right now?
This one, right here.
And don't take it right after they walk in, because it's
There it is.
it might be up.
That'll work.
Yeah.
So we should write in the groups which one of you wants to be the reconvener. Why don't you go ahead, so you guys are trading off. Thank you for filming.
I'm having fun.
Yeah, I could do that.
You want to do that? Okay. Hello? Gosh, sorry, that was loud. If we could get everyone's attention, we want to be able to leave some time for Dr. Thompson to give her updates. So what we'd like to do is get into the report back session.
Where are you all going?
You're on, right?
Where are you all going? No, I'm not going.
So we had 3 questions that we gave to the group. If I can get everyone's attention, that'd be great, thanks. I'll just read off the 3 questions and then we'll go around the room. We'll start with the first question and Dr. Rebelo will help. He's got the mic, so don't be shy. Oh, good, we have 2 mics on both sides, this is great. So the first question today was, based on today's presentation, which new guideline will you implement in clinical practice to reach the goals for blood pressure and lipid control to prevent heart disease and stroke? So if anyone wants to start.
Oh, I'm sorry. I think James wanted to mention something before we start. There is a meeting, before we have the first presentation. James, did you mention that meeting that's coming up?
Yeah, so there's it's actually, it's called Getting Patients to the Right Health Plan. It's an initiative that's being put forward by the National Health Council and Dr. Richard Pan, who's a state assembly member, who's the chair of the healthcare committee, and Mark Oden, who's executive VP and CEO of NHC, are putting this on. It's on March 13th. From 2 to 3:30, and it's a healthcare stakeholder, leader, and legislator staff briefing. So for those of you who are interested, I have some flyers also. If you just want to drop me your card, we can get the information out to you. It's kind of short notice, but thank you very much for the opportunity to speak that.
Thanks, James. Sorry.
Oh, no problem. I'll read the question again, and then we'll maybe start on Dr. Orlo's side of the room. So, based on today's presentation, which new guideline will you implement in clinical practice to reach the goals for blood pressure and lipid control to prevent heart disease and stroke? Anyone come up with any new?
Like you say, from our table, what we we're talking about, we said, well, really, we want to implement the JNC8 and the ATB4 guidelines. I mean, there's a lot of intelligent people that worked on them, and just like every time these guidelines roll out, it's a lot of it is getting the education out there. It's also changing some of the things in our EMRs as far as, so that we can highlight those patients who are now in those, that have those issues going on. We did think that it was very positive. They standardized the blood pressure for 140/90. That I think is we use more of a team approach to take care of our patients. When you're asking an 18-year-old to call a multitude of different patients and you keep changing what the blood pressure target is, if it's confusing for them, it is confusing for the patient. And so, the fact is, as a country, we just haven't done great at getting, the majority under 140/90. So our sense was, let's get everybody below 140/90, and then maybe 10 years later, we'll start really focusing even more on those higher risk groups to try to get them down lower. But we think that, as far as a national priority, will really help. Just, this is the goal. This is what all of us need to step up to. And then the other piece is, we think by reducing the lab requirements for the lipid panel, the lipids, that will also be very helpful. That we think that when we tell the patient, yeah, we're going to help you lower your cholesterol, but we're giving you this medicine which could shut down your liver, and we've got to do blood tests, it makes them go, what? I feel fine right now. Why would I take something that could harm my liver? And I think the studies have shown that the risk, the benefits far outweigh the risk. So now being able to say, hey, you know what? We're going to start you on this. And then if you start having problems, come back and we'll follow up. I think that's going to really help move us forward in getting more people on the medication and improve compliance. That's it from our team.
Great, thank you.
Right, thank you.
We had a pretty great discussion from a more peripheral policy and administrative perspective, and just a couple points we wanted to make to the group overall included. Number one, there is often disparity between formularies from health plan to health plan in terms of what's covered or not covered, brand name or generic, whether it's covered by Medi-Cal or not. So keep that in mind as you move forward with these recommendations and when you talk to groups, because that can be very sensitive, an issue. And the standardization of formularies may be something in the future we want to talk about so that everybody's able to incorporate these recommendations because we have access to the medications. The other point I wanted to make in terms of the presentation today, standards across the board are helpful. We reiterated what was said earlier about it, the clinician decision support in the EMR, having this incorporated is important and critical so that the staff that help to support this understand that workflow. So again, kudos to that concept. And finally, I just wanted to say, the work we're doing together, I think the presentation made me feel reaffirmed to this group and to the work of the California Wellness Plan that these issues have not yet been addressed based on what we've talked about. So I'm kind of reaffirming my commitment to the work we still have ahead and appreciate the practical review today.
Great, thank you. I think we have one.
Could you just say your name and who you're with, and if we can make that our standard, then everybody can get to know each other.
Sure, I'm Wanda Borges with USF. And we talked about some of the controversy around the risk calculation tool and how that's sort of a problem because it hasn't been tested. And so I offered that we have a new health informatics program, and they're looking for projects and having an app developed that providers could use along with the Framingham app that could compare that might be a way to do that, but of course it needs to be tested. And then since I was at the table with Gil, you want to tell them about your 74% improvement?
Yeah, that's the latest bit of information that just came from Chad. I had no idea that 74% of our hypertensive African Americans are now under control.
Wow.
I can speak to that a little bit. So in the first quarter, when we looked at the data, you were about 55%. And the following quarter, the very next quarter, you'll be 73, and you've maintained 73, 73, now 74 in the most recent quarter that we've reported for that particular group within your practice. And so, it's terrific work that you've done, and we really appreciate that.
And we really appreciate the Health Services Advisory Group providing that technical assistance. Great to
Over here, actually, in the table. My glasses are on. So, Juliana, sorry.
I am Juliana with UC Davis. So our table got a little off track, and I think it was good that we did. So we actually have a patient at our table. So that was actually a very unique experience for us to kind of talk about these types of things in front of a patient. So as we were sitting there talking about, oh, we like 140/90, or no, 130/80, no, we like the statins, no, we don't like the statins. She's saying, what are you just talking about? And how am I supposed to trust that? How am I supposed to trust you guys if you guys don't even know what you're talking about? So the other thing we mentioned and we were looking at is we were looking at some of the graphs that we saw earlier. And although we saw people were getting more under control with hypertension, more under control with hyperlipidemia, the food issue was a big issue. And so she represents a lot of farm workers. And so they live in a food desert. They work outside all day long. They pull vegetables out of the ground and they don't get to eat them. So we're kind of looking at it from a different perspective in that we really kind of have to focus on this food aspect of things and some of the barriers our patients have before we can even get to all of our fighting about 140/90.
All right, yeah.
Dr. Buss. I just wanted to add that, I don't know if any of you went to the Measure of Pressure Down webinar that they had in February. And the Measure of Pressure Down has decided to embrace 140/90 as their standard for everybody. I don't know if any of you guys are aware of that, because they did some data analysis and they decided that the difference that they're going to have in statistics would not be that different if they use 140/90 for the whole population or 150/90 for those greater than 60, because so many people greater than 60 actually have diabetes or chronic kidney disease. So that, in my mind, kind of made it simpler to think about how you do data collection as a system. It's actually almost in some ways easier if everybody is 140/90 for your data functions.
Great, good point. Anybody else?
I want to make a comment because we haven't announced this yet to the group, but our sort of leadership team in Right There has at least got to the point where we're really going to focus in on Measure Our Pressure Down as a critical, and we haven't fully talked, I don't know if we've talked to Hector about us moving forward, but we think that this could be a great project for us here because, first of all, this is just amazing, information helping drive that this is really a great program, and we should be working with all our health systems and the county and all our partners to identify that this could result in some really great improvements, just like Dr. Simon has done. And we're excited about this. We're excited that this is something that Measure Our Pressure Down could really get behind as an organization. And you'll be hearing more and more about this as we go forward. So great news today.
If you don't have any more comments, we can probably have Dr. Burnson come up.
So now I'd like to introduce to you a good friend and a familiar face to you all who has been here before. She's the CMO of the Region 9 CMS Region 9 office, Dr. Betsy Thompson. She will give us a little federal update on what's happening at the federal level in terms of physicians and other initiatives that are coming down the pipe.
I do have a couple of slides, if I can get to them here. There we go. Looks like it. It's always a pleasure to be able to come here. I don't make it every month, but I always enjoy hearing about what's going on, and I love the collaborative nature that what happens in this room and outside of the room for that matter. Because of the topic today, I wanted to tell you a little bit about where we are in the Million Hearts campaign. I hope all of you have personally taken the pledge to help reduce heart attack and stroke by 1 million over a period of a few years. We're actually about 24 months into this project, into this initiative from when it was launched, and I wish I was here to tell you about interim results in terms of how many heart attacks and strokes have been prevented. We don't have those data yet. My colleagues at the Centers for Disease Control and Prevention are working on the data evaluation plan, and I think we're all quite confident because of the work that's going on across the country, similar to what's been talked about here, that we will see some major successes with this initiative. Is everyone familiar with the Million Hearts campaign? Anybody that's not, you probably are afraid to raise your hand now, right? Okay. And really, I do encourage you, we're still loving to have people as individuals or, whether you're patients, healthcare providers, or institutions, to take the pledge, because that shows the support and focus on this too. But as you know, if you're familiar with it, we kind of have two arms. One's community prevention, focusing on the things listed on this slide, mainly tobacco control, sodium reduction, and trans fat elimination. And then on the clinical side, focusing on the ABCs, as well as health information technology and clinical innovations. At 24 months, like I say, these are the kind of results I really want to subscribe to you. Yes, we have 61,000 likes on Facebook, but I want to know what that translates to in terms of lives saved. We have developed a lot of tools and resources for providers, healthcare providers of different types to use. We have an update that goes out. We have 43,000 subscribers to that, and we have a number of true people, not that have just signed on, but have actually become partners in this endeavor, is well over 86, with over 1 million visits to the website. One thing I did want to let you know, when we started this, it was really CDC and the CMS in partnership that launched this, but we have many of the HHS agencies involved. In fact, this slide outlines how the different federal agencies are involved and how that has changed just from September of 2013 to December of 2013. So for example, in terms of translating and diffusing knowledge, we've had Federal Occupational Health, the Office of the Assistant Secretary for Health, and SAMHSA, the Substance Abuse and Mental Health Group. They're all in red in that little box. They've all signed on and started working in that area just since September of 2013. So our focus as federal agencies and as sort of the leaders for that has been to get other agencies involved, not only in the translation and diffusion of knowledge, but
really taking measurement of this very, very seriously, how important it is, so that we can get systematic measures and reporting that help give us those results we want to see, to help that are believable. Part of doing that is to create and align incentives across our healthcare system, and I think we've talked about that before in terms of just how important it is to align our payment incentives at CMS with the outcomes we want to see, but also aligning the measures across different programs. And if any of you have been paying attention or been forced to pay attention, you know that our clinical quality measures, for example, now under the EHR program, or meaningful use, and the physician quality reporting system are aligned, and you can report those at one time, actually. If the proposal to fix the sustainable growth rate that's sitting in front of Congress now is passed, and you know, I'm a federal person, so I can't tell you to go out and lobby for that, but you know, if you did, it'd be okay with me. That will actually, part of that is not only fixing the sustainable growth rate, but it's bringing all of our incentive programs together under one umbrella, instead of the 4 different acts that they were actually launched under. So I think that could really help in this area too. Population health, a big deal. I mean, something that we constantly struggle with and really need to pay attention to, getting a lot of stakeholders of each of our individual agencies activated to play an important role, and finally the role of research, which, you know, frankly, we do less of at CMS than many of our sister agencies, although they're often using our data. So those are sort of the areas that we're trying to get our federal agencies involved in. We know that for this year, some of the things that we need to do is be very clear about the signal that we're sending, and really it's kind of a simple message, right, that about preventing heart attacks and strokes and what you need to do that. And we heard a very good presentation on that today. And I think it's nice that we have a cross-section today here, because it's not just about healthcare providers knowing this, it's about the public and the patients knowing what they can do, and it's about healthcare systems, payers and purchasers being involved in that. The second thing, as I already alluded to, we really have to get the measurement and report progress out there, and I hope that the next time I give you an update on this particular initiative, we'll have some real numbers to be able to report to you. And then really most important is, you know, finding those people at risk and doing what we can to help with control of blood pressures and as well as smoking cessation and aspirin use when it's indicated in cholesterol lowering. So we're doing a lot of things for each of these strategic directions. I want to draw your attention to the middle box here. And we know that we need to help everyone with implementation. That's one of the biggest things in terms of translating and diffusing knowledge. It's often not a matter of knowing things, it's about how to implement that knowledge. When it comes to measurement and reporting, there's a lot of work that needs to be done here. That's, again, draw your attention to the middle slide there. One thing I know that we don't do as well at the federal level as we'd like to, and that is timely feedback. I think we're getting a lot better actually at transparency, but the timeliness of our data is often lagging. And then in terms of creating, aligning incentives, making that business case for prevention is something we continue to work at. CDC's done a lot of work in this area and will continue to do that. For activating stakeholders, we need additional performance data. We think is one of the main things we need to really bring more people to the table and get them to throw some resources behind this. We've talked about this a little bit today too, how to transition when you're changing your cholesterol targets. How do you transition without losing your trend data and being able to get reliable data over time, which is what we want to look at. It is challenging. We have to change sometimes when the evidence suggests that, but it always creates a problem in terms of measurement. And then finally, continuing to look at what works and why, which is so fantastic about what you shared here today, about what you're doing and what works. I think the rest of these, there's more we could talk about in some detail, but I wanted to stop there and just also mention that we had recently announced, the CDC had recently announced the 2013 Hypertension Control Champions. I want to draw your attention to the fact that we have Kaiser Permanente in Northern California on this list, as well as the VA. So together, I just, these, how many do I have here? 9 for healthcare providers. It's 8.3 million patients that they've been taking care of. And if you look at them, you'll see that they represent, it's a fairly broad representation. There's small and large systems here. There's individual physicians. They represent urban and rural areas, private and federal facilities. So it's a pretty diverse group. And what they were actually able to achieve was blood pressure control in the range of 73 to over 90% in their population. So we've heard some successes here that are up in that range, so you all are champions too, in my book. But that's what we know we all can do, right? We can get up into that range. And who knows, we might even be able to exceed it. So I think that is the last slide, except for directing you to the web site. If you haven't been there in a while, we have been adding resources. This is the web page I showed here, was the resource one, because I think it's the one that's pertinent and relevant. So initially the toolkits I thought were a little sparse, but there is more there in terms of the action guides and the toolkits for healthcare providers to use if you want to look at something else. I'm going to stop, but I really am here to answer questions, not just about the Million Hearts, but anything else under CMS's rubric. I think we have just a few minutes, so I'm happy to do that. Thank you.
Betsy, you couldn't be with us last month when a really energizing discussion took place. We had Dr. Alan Schatzel, the head of neurology for the telestroke program of the Dignity Health System, talking about how he often receives a patient who is unconscious for whom he has no data. And that started a conversation about whether we could get some functional clinical data moving at least between the systems of the Sacramento region. And I'm wondering if you could say anything about any help along those lines that might be coming.
No. How's that for an answer, Eddie? The health information exchange is so critical to all, maybe not to the 90% of the work you do on a daily basis unless you're in the ER, and then it probably is critical to 90% of what you do. But it's those times when you need it, it is so desperately needed for the kind of reasons you're talking about, when you have somebody severely ill and no information about them. So we have to solve this issue, and as we have shown over and over again in just the state of California alone, it's not easy. It's not even easy on a regional level. We've had HIEs that have come and gone. We've had some that have been successful. We have not made it, and the Office of the National Coordinator, the reason I say no from CMS's perspective, this really is our sister group, the Office of the National Coordinator for Health Information Technology. This is their area. I cannot speak for them. But they did throw significant funding behind this, and that funding sort of ended. And do we have a statewide HIE? We made a lot of progress, a lot of false starts, it seemed like, but we made a lot of progress in California. We have some states that are further along. We have some regions within California that are doing well. But in terms of future funding, Hattie, that would not be CMS. And I don't know, we've spent a lot of money on this. We know there is commitment at the federal level to make this work, but we have no authorized additional funding for it at this point.
I wasn't really putting you on the spot for funding, sorry about that. I meant more like, what's the strategy? Is it gonna be like a cloud-based strategy, or are we gonna have chips in our driver's license?
We need the innovators here to tell us that. I mean, I think whatever it is today, it's going to be different tomorrow, right? And it also is not the same solution everywhere, at least at this point. At some point, I hope it is, because we really need a national HIE, but we may have, and I know we have already, we have regions that are doing this with a cloud-based strategy. We have others that are doing it on hard servers, and then we have networks where everyone who's using Epic or Cerner or something is doing it in a plan-based fashion. So right now, there isn't a one-size-fits-all answer to that. We know we have to do it, and we know we have to get there. I don't see it happening anyway nationally. I mean, I'm not a techie person, you know, but when I talk to people who do know a whole lot more about it, I don't see how it can happen on a national level without it basically being a cloud-based strategy. Sacramento, you know, again, what's been tried here? I think things have been tried, and learning from what's happened in the past and building on that rather than just scrapping it and saying, oh, we got to start over, is probably what's going to serve you best. But I don't pretend to be any expert in the Sacramento situation. I just know you need to do it.
Well, Dr. Revla is trying to take the lead on that.
Oh, so ask him the question.
Yeah, well, we're very, very early on, and what we're trying to do is identify the previous experiences and where it's sort of bogged down. But there's a lot of interest by the individual health systems. It's just a matter of trying to find common ground. And we're looking actually at the common ground here. It looks like we could, and Diane and Robert aren't here yet, so I can make this comment. Hopefully they will come back to haunt me, but we feel like Sierra Health Foundation can play a very critical role in being where it's not threatening for somebody who has a Sutter monocle or somebody who has, you know, something else behind them coming in and trying to lead it, because it's about the community. It's about it also including, you know, not just the four health systems, because Kaiser is also involved in this, but also going beyond, looking at the county system, looking at the community clinics, looking at you know, the individual areas like the private pharmacy, CVS, and that we really need a large group of people coming together to recognize it just for the benefit of the community. And we think that that's what it's going to. Colorado's already, you know, way ahead of most states doing this at the statewide level. And I think it's going to happen that, you know, that it probably can't happen top down, national down, that it's going to need to happen at regional levels with experience, sharing those experiences, and then eventually having the spread where we can develop what is called the National Health Information Network. So we're really excited. We're early on. We don't have any money. We don't have. We just have ideas.
Great. Other questions?
Although Ralph is with me all the time. He's my boss back there, and he's a little surprised that he's hearing this from me. but it is a very important piece, even for our organization at SIP.
Well, it has to happen, and it has to happen in a very inclusive way. So I like that, you know, you're talking about there in terms of a neutral convener and someone that can help bring everyone to the table. All right. I guess that's it.
Yeah, great. Thank you. Looks like we're at a 2-minute warning. So I just wanted to remind you again, the blue sheet is the CME and CEU. If you know, go to the website, fill it out, get the CME credits, because I know everyone's time is precious these days. And also in their packet, there's a yellow sheet that gives the next University of Best Practices the dates and when the summit is in the fall, just so you can keep that on your calendar. Just as a note, in May, we're changing the date. It's going to be the first Monday instead of the second, just due to a scheduling conflict. So with that, have a wonderful week, and we'll see you next month.
You also received an email from Carla with the instructions, look just like this, with CME. So you just click on it and go.
Thanks, everybody, and thank you to Sierra Health for hosting us.